a very hot welcome, a very warm welcome to this NB Medical Hot Topics clinic all about bladder cancer this evening. It is absolutely fantastic to see so many of you joining us tonight. I did wonder when I was just trying to cool off when I got home from work this evening, how many people would be joining us for the free clinic this evening, given that it is such glorious weather outside. So a massive thank you to you all for signing up and signing in this evening. That makes both my role and Shiv's role that much more enjoyable. So quick round of introductions before we get started. We feel a little bit like we're on the clock when we do these clinics because the hour goes so quickly. So my name, if you've not met me before, is Kate Digby. I am a GP partner and a GP trainer in Cirencester, which is in the southern bit of the Cotswolds in Gloucestershire. I have a bit of a portfolio role. I am a TPD or a program organizer for our local VTS scheme, and I have, for my sins, recently taken on a role within our PCN. Been doing NB medical work now for many, many years, presenting on our various courses, and as the cancer lead, I thoroughly enjoy delivering these free sort of golden nuggets of information when it comes to really hot topics within the world of cancer. Now, the really good news for you is that you don't just have to listen to me for the next 60 minutes, because I am joined this evening by the rather fantastic Shiv Becker, who's over in Oxford. Shiv, are you there this evening?
Yes, Kate, I am. Thank you very much. Lovely to be here. Yeah, equally hot and sunny where I am as well. My room at work, I'm sure some of you can share this pain, gets all the full afternoon sun all afternoon. Obviously, there's no air conditioning. So, yes, feeling slightly sort of faint now, but promise not to complain about the weather. As Kate says, I'm a GP. I've been a partner for over 21 years, in fact, and in the same place, which I absolutely love. So it means that I have grown up and grown old with my patients. So I have had loads of patients go through their bladder cancer journey over the last 20 odd years. So I find this topic really interesting. Kate's got loads of great things to say about cancer and things that we can learn about in primary care. So I think it's going to be really useful for all of us. Please do send me in all of your questions. So I'm here to answer all of your questions. At the end of every sort of 10, 15 minutes or so, Kate will pause so we can go through some of your questions. Please let me know any questions, but also let me know how things are in your area, maybe what services you have access to. If you've got a brilliant urology service or a really terrible urology service, we want to know all about it. If you've had any good experiences or difficult experiences, please let us know. We really want to share in those. Anything you send in to me will be anonymized. I'm not going to sort of read out your names or anything like that. So there's no question too small or too large. Please just let us know how you're doing. I'll hand back to you, Kate, to get on.
That's fantastic. Thank you, Shiv. We will see you again shortly. And I ought to say, we've also got in the wings, so our silent partner this evening is Daniel. He is our IT guru. So if you have any problems at all with the technology, then drop a little note into the Q&A box and Daniel will be able to help you out. So if you've not joined us for any of our NB clinics that we run, then just to sort of give you a bit of a flavour as to what the aims are for the next hour. Because we run these free clinics every month, near enough, and it's really just to give you some of the really sort of bare bones hot topics on what is going on in the literature at present. Tonight we are working in conjunction with Action Bladder UK, and we are aiming really to update all of us that work within primary care about sort of the facts and figures relating to bladder cancer, what it's, the rate of bladder cancer, the survival, what things we can be looking out for in primary care. We will, of course, have a look at the current guidelines, and those are the guidelines that help us to decide who we're going to refer into secondary care for further investigation. And we're going to hinge all of that, all those updates on some relevant case studies that you can almost imagine walking into your room later on this week. Within the presentations, I've actually got some polls. That's just really to gauge the nation and the mood of the nation, just to get some ideas from you as to how you would manage the patients that we discuss. And you will find, if you've not seen it already, there is a resources tab somewhere on your screen. And that's just got the links to the specific papers which we're talking about this evening. Also, some really good resources to share with patients that ABC UK have put together for us. So have a little look at that. As Shiva said, she is manning the question box, so just keep her busy for the next 60 minutes. She likes nothing more than to have lots of questions to answer. Okay, let's get started, and let's think about the facts surrounding bladder cancer to start with. So bladder cancer is actually pretty common. There are over 20,000 patients diagnosed with bladder cancer each year in the UK. And that figure of 20,000 plus includes patients which are diagnosed with very early types of bladder cancer, what they now call the non-muscle invasive types of bladder cancer. That's included in that figure. And bladder cancer, like many of the other cancers which we diagnose and manage, has the survival strongly linked to the stage at diagnosis. So obviously, in an ideal world, we'd like to be picking up the bladder cancers when they're at that non-muscle invasive stage. If they're diagnosed really, really early, or even at stage 1, then this 5-year survival is really good. It's about 80% currently. Now, if bladder cancer doesn't get diagnosed until much later, when we're looking at stage 4, then actually that 5-year survival drops to about 20%. So you can see there's a real drop-off in the prognosis that patients are given depending on their stage at diagnosis. And what's interesting, and we'll come back to this in one of our cases a little later, is that survival's often less favourable in women compared to men. And that's because actually, currently, women are more likely to be diagnosed at a later stage in their bladder cancer journey. Now, bladder cancer, not only is it common, it's also one of the most expensive cancers to manage on the NHS. It costs the NHS about £65 million per year. And that's because the technology that's used to manage bladder cancer now is actually quite expensive. Now, given it is so expensive to manage all these patients with bladder cancer, it's almost a little bizarre to think that actually, compared to other cancers such as bowel cancer and breast cancer, bladder cancer receives a really small proportion of research funding here in the UK, and it's been coined the Cinderella cancer as a result. Now, the reason that this is relevant and the reason that there's almost a drive for change is because what we've seen in recent years, that survival hasn't really got any better. And that's a real contrast to other types of cancer. If you look at bowel cancer and breast cancer survival, they've all improved over recent years, whereas for bladder cancer, it's remained pretty static. The other problem with bladder cancer is there's a fairly high rate of recurrence. So people live with it and then have further problems down the line. So let's have a little think about risk factors for bladder cancer. It's far more commonly seen in men compared to women. About 75% of cases are seen in men, and it's far more common as you get older. So it's far less likely to occur in anybody under the age of 45. But that's not to say that it doesn't, and it's still a diagnosis of consideration if you have a patient presenting with typical symptoms. The biggest preventable risk factor for bladder cancer is smoking, and bladder cancer incidence is 4 times higher in smokers compared to non-smokers. In fact, around half of all bladder cancers are linked to a history of smoking. But smoking's not the only risk factor for bladder cancer. There are lots of other ones as well. Perhaps the one that we often come across is the exposure to chemicals, especially arylamines, which are nasty chemicals that are often found in the dye, rubber, plastics industries. In fact, many arylamines were outlawed many, many years ago. But what we see from an occupational exposure risk is that they may have been exposed up to 30 years before their bladder cancer symptoms developed. So taking an occupational history is actually fairly relevant when it comes to bladder cancer. Other risk factors, and bear in mind that whilst I've listed out the sort of most common associated risk factors, this is not by any means an exhaustive list. There are other ones as well. But having repeated or chronic UTI infections, having schistosomiasis, history of bladder stones, even neuropathic bladder is a risk factor for bladder cancer, down to the neuropathic bladder leading to urinary stasis. That's thought to be an independent risk. Having a positive family history, especially in a first-degree relative, puts your risk of bladder cancer up. And then exposure to some drugs can also increase the risk as well. And one example of a drug association is cyclophosphamide, but also don't forget the recreational drug use, especially with ketamine, that causes all sorts of bladder trouble. Stands to reason, I expect, that radiation exposure is a known risk factor. We can imagine how having that sort of focal pelvic radiotherapy can cause all the trouble. Now, we can't really gloss over the impact that COVID has had on sort of what is happening within the world of bladder cancer diagnosis and management at this point in time. And this was looked at in a bit more detail in a retrospective cohort study published last year, asking the question, are patients presenting now with more aggressive disease compared to before the pandemic? And what they found within their study was actually far fewer bladder cancer procedures were performed during that COVID period. During the period of lockdown, when patients didn't present so frequently, we had fewer bladder cancer procedures. And as a result, when they looked at the data taken from later on in the pandemic, there was a far higher rate of more advanced stage and grade of bladder cancer disease, suggesting that patients are now presenting later. And this is one of these interesting findings that really encourage, in an ideal world, would encourage people to think, like, there needs to be some more funding to try and increase the resources available for the management of diseases such as bladder cancer. And evidently more studies are needed to further evaluate the long-term impact of COVID on bladder cancer outcome. Now, why? This is often a question asked. What was the effect of the pandemic on presentation and diagnosis of diseases such as bladder cancer? And of course, we know just from having worked through the pandemic that the reason patients didn't present to us as regularly was multifactorial. You had the patient factors, such as their reluctance to bother the GP or the fear of attending hospital appointments. Patients just literally hunker down when Boris said stay at home. That's literally what many of them did. But as clinicians, we moved to remote consulting. So, pretty much overnight, we switched from a face-to-face model to a remote consultation model. And that meant that we saw far fewer patients face-to-face during the COVID pandemic. So our sort of hands-on assessment of patients became far more remote. And as part of that, sort of from a system transition, we've tended to move away now from dipping urine so much, because Public Health England, when you look at the UTI guidelines, don't recommend we do as many urine dips as we used to do. And if you think about the last time you managed a UTI, vast majority of UTIs are now managed remotely. That's just become the norm. So we need to have our wits about us, really, when it comes to thinking about the types of patients who actually may be presenting with early bladder cancer symptoms. We need to be aware of what those symptoms are. Now, the most common symptom for bladder cancer is hematuria, and it's not constant hematuria. It's quite often intermittent bleeding. And so therefore, the take-home message with that is that don't be reassured if somebody has an episode of hematuria, especially visible hematuria that they report. We can't be reassured if the bleeding then stops, because an intermittent pattern is most commonly seen. UTI symptoms are quite common: frequency, urgency, and dysuria especially. And a history of recurrent UTIs ought to sort of raise a few warning flags as well. Now, just sort of to be clear as to what we talk about when we're talking about recurrent UTIs, we're talking about 2 or more UTIs over a 6-month period, or 3 or more UTIs over a year. Other symptoms or signs that you may see with bladder cancer would include non-visible hematuria. especially if that's associated with any sort of unexplained urinary symptoms such as dysuria or urgency. And then more constitutional symptoms as well. So perhaps some loin pain or some lower abdominal discomfort, just general systemic symptoms like fatigue and malaise and that sort of thing. Just think sort of that, cast that wider umbrella when it comes to thinking about diagnoses for patients presenting. We, of course, depending on where you work in the UK, are sort of governed, our referral practices are governed either by the NICE NG12 cancer referral guideline, or if you happen to work in Scotland, you've got separate Scottish referral guidelines for suspected cancer as well. And actually, Action Bladder Cancer UK have currently got NICE having a look at their guidelines for referral, given that they haven't been updated since 2015. But at the moment, this is what we are looking at in terms of who should we really try and identify in order to get referrals done in the most timely way possible. So let's have a look. The guidelines are very similar. There's a couple of distinct differences, as you will see just from this table. So both the NICE guidelines and the Scottish guidelines agree. They're unified in their recommendation that anybody aged 45 or above with unexplained visible hematuria and no UTI ought to be referred down the 2-week urgent pathway. Also in agreement, they recommend urgent referral for anybody with visible hematuria, which either persists or recurs after a UTI has been successfully treated. Both guidelines have got recommendations for what to do with non-visible hematuria, though you will see that there is a slight difference between the two papers. So, according to NICE NG12, anybody aged 60 or above with unexplained non-visible hematuria and either dysuria or a raised white cell count ought to be referred. For the Scottish guidelines, we're looking at anybody aged 60 or above with persistent, unexplained, non-visible hematuria and no UTI. And then finally, NICE recommend a routine referral if you have anybody aged 60 or above with either recurrent or persistent unexplained UTIs. And in Scotland, they also make note of the recommendation for urgent referral for anybody with an abdominal mass thought to arise from the urinary tract. So you can see that there's a fairly well-defined group of patients that we ought to be considering referral in, depending on how they present. And you can well imagine you will find yourself in that situation where you have a patient in front of you when you're, I call it my spidey sense, but when your spidey sense is tingling and when you think, I'm not happy with what's going on here, when you have clinical concern, but actually they don't quite fit the criteria, what can you do in that situation? Because that certainly is a situation I'm sure we all find ourselves in fairly regularly. Don't forget the beauty of advice and guidance. And advice and guidance is a great way to get sort of secondary care input for patients who you're just not very happy with. But trust that clinical judgment, because these guidelines are there to help direct the flow of traffic. But if you've got significant clinical concerns, then act upon them. Don't just stick to what the guidelines say. Don't forget the importance of safety netting these patients, especially if you have that clinical concern and there is an element of uncertainty as to the underlying diagnosis. So really share that uncertainty with patients and encourage them to come back to see you again if those symptoms persist, or indeed if they get any worse or change. And you might just want to reflect on your safety netting practices. Do you routinely send scheduled follow-up text messages, for example? Do you schedule yourself tasks to look and make sure patients have been reviewed? It's that sort of safety netting practice which is worth considering. And if you haven't already seen it, sometime last year I did a safety netting clinic just like this one, really looking at more of the detail in what's currently recommended from safety netting practices. The final thing we just need to remember to reiterate to patients, and we've been saying this, of course, for months now since we came out of the came out the other side of the pandemic is that, it's that message of reassurance that hospital environments are essentially COVID safe now. We're trying to get back to business as usual, and therefore they shouldn't have any particular concerns around attending any hospital appointments that you might refer them in for, because, we want to get these patients seen and assessed by secondary care, and we don't want them to stay away because of the concerns they may have regarding COVID. Okay, so let me just pause there for a second and let's go to Shiv. Shiv, how are you doing on the questions over there?
Great. We've got loads. Thank you very much. So, thank you all for coming in with all of your questions. It's great to hear from you all. Glad you're all lively and awake at this time in the evening. So a recurring question is about recurring hematuria. So people asking about what counts as persistent hematuria. So certainly I do this, and I was just wondering, where do I get this from? So I just had a look, and it's actually from my local guidelines. It's 2 out of 3 samples having hematuria. So I think if you are saying, when do we say it's persistent after a UTI? If you get them to do a repeat, there's still hematuria there. I would do 3 repeats and only be happy when you've got, at least 2 of those clear, the second ones. But that's certainly what our local guidelines. I'll go to Kate in a minute and see if she's got anything different to say. But that's from our urology department, is if you've got 2 out of 3 samples that have hematuria on dipstick, then you count that as persistent hematuria. Somebody else asking, when we say raised white cell count, is this in the urine or in the blood? No, it's in the blood, actually. I have a feeling Kate might be going to be talking about this in a minute, yes, she's nodding, about leukocytosis associated with bladder cancer. So she's going to talk about that in a minute. I don't want to spoil that, so I will let her talk about that in a minute, but it is the blood count that you're talking about. Lots of questions about the persistent hematuria. This is really, thank you for saying yes to this. This is one of our colleagues, and I'm going to read this out because it's so useful. This is from one of our colleagues as a GP with bladder cancer. My learning points are: A, bladder cancer is very uncomfortable. Although it presents with painless hematuria, the cancer and the treatments irritate the bladder, which is very uncomfortable, I'm sure, and symptomatic. And nocturia 3 times a night causes chronic fatigue. Endless catheters are no joke. And unfortunately, bladder pain does not respond well to analgesia, I'm sure. Macmillan has got good resources. And the third point, dip the urine and do not ignore a little bit of blood. That's a really useful point. Thank you very much. Which also answers the other question which somebody else has asked, I think, of when is it hematuria? How many pluses of blood do you need? 1 plus of blood is enough to call it hematuria. That's a really salient point. Thank you very much. Lots of questions about the hematuria, so I think we've covered that now. Does menopause have any bearing on non-visible hematuria? Yes, that's a really good point. But again, I think Kate's going to talk about perimenopause later on, so I don't want to spoil her pitch, so I will wait for that. And then if it's not all covered, I will talk about that at the next break. Is there something I can say to a patient who insists on having an antibiotic and refuses to drop in a sample? Ooh. She says she always gets UTI and doesn't need a sample. Yeah, that's tricky, isn't it? I tend to agree with you. I think you kind of do need to have a sample every now and then, because quite often you may just be treating dysuria and maybe she's got chlamydia. I think that you do need to insist on samples for recurrent UTIs. I actually agree with you about that. And then I think we're just into lots of things about repeat dip in the urines. I will go carefully through all the questions now. I'll let Kate get on, and if there are any other ones, I will answer you in the next Q&A. I'll go back to you now, Kate.
Thank you very much, Shiv. Brilliant questions, and thank you to the delegate that shared their experience of bladder cancer. That's really valuable first-hand information. So thank you very much for sharing that. Yes, I think we're going to cover, we'll talk a little bit about persistent and unexplained now in our first case. We will touch on a bit of menopause or a menopause-related case and a bit about non-visible hematuria. So we've got 3 cases and we've got 35 minutes. So that's plenty of time to unpick these three cases. So this is the first case, and this is John. So John is a 69-year-old patient, pretty well 69-year-old. He's fit, he's active. He's only got two significant medical problems at this point in time. He's a known hypertensive, and he has atrial fibrillation. So to that end, he is on edoxaban and he's on amlodipine for his blood pressure. Now, John's a 69-year-old chap, and he's had at least a 6-month history of some urinary frequency, but he's not been particularly bothered by this frequency. In fact, he's put it down to old man bladder, which his mates, when they get together to sort of chat about retirement and what they've been up to, they all sort of compare notes on what their bladder symptoms are like, and the ins and outs of how many times they're up in night and what their stream is like during the day, as I think lots of patients do. So the reason John has got in contact with the surgery is because last week he had a single episode of visible hematuria. And when it happened, he didn't have any symptoms that would sort of make you think about a UTI. So he didn't have any dysuria, he didn't have any fever, didn't have any particular pain. He felt completely well in himself, but he did notice that his urine went a good proper pinky rosé colour and then returned to normal. So, quick question for you now, and this is where we're going to see if the polls are working this evening, is what do you think you would do with John? So he's a 69-year-old chap. He's on a DOAC for atrial fibrillation, and he's had this single episode of asymptomatic visible hematuria. So what's your management plan for John? Would you get him to bring a urine sample in and send it off to sort of try and identify whether there's an infection present? Would you dip that urine to make sure that the bleeding has resolved? Has John given you enough reason to refer to urology at this stage? And if you're going to do that, would you do it either as an urgent 2-week referral, or would you do it as a routine referral? Would you think about stopping that DOAC and then monitoring to see if the visible hematuria recurs? Or would you, given his presentation, empirically treat him for a UTI? Let's just see what the general mood of the room is. And there's so many people on tonight that we'll just give that a few seconds for people to decide. I'm sorry, a choice of 6 is probably a bit much for 8:30 at night, isn't it? I apologise for that. Let's have a little look and see what people think they would do for John. Okay, so let's have a look. Very few people are going to empirically treat him or routinely refer him. Very few people are going to stop the DOAC and see if it recurs. So there's a good spread there, isn't there? But the two front runners from this question is either send an MSU to look for evidence of infection, or in fact, nearly 40% are going to refer to urology as a 2-week referral. So thank you for getting involved with that poll. That's really helpful, because this is where we're getting into the realms of what is the definition of unexplained visible hematuria. And unexplained hematuria refers to patients who do not currently have any conditions that can cause that hematuria, whether that's renal stones, whether that's UTI symptoms. So this is in John's case, because he was completely asymptomatic when he had his visible hematuria. That is what we would call unexplained. And it's really important, even if he's only had one bleed from, one clear visible hematuria, we mustn't assume it's down to the fact he's on a DOAC. It might well be related to the fact he's on a DOAC and consequently a bit more bleedy than somebody that wasn't taking edoxaban. But before we can blame the DOAC, we need to exclude the bladder cancer first. And the take-home message here is that even a single episode of unexplained visible hematuria warrants a referral and investigation, because actually intermittent hematuria is the most common presentation for bladder cancer. And you only need to have one bleed from your bladder to have a bladder cancer. It's not a question of, if you've had 2 or 3 or 4 episodes that it makes it more likely. Yes, it does, but we want to be referring after the first one. And that ties in with what the guidelines recommend, both from NICE and the Scottish referral guidelines, would be to refer him because John is 69. He's had this unexplained visible hematuria episode. We had no reason to think he had a UTI. Now, if the presentation had been slightly different, and if John had had symptoms suggestive of a UTI, then it would be absolutely appropriate to send an MSU and to treat him for that UTI. If we're going to do that, especially if the UTI is confirmed, we then subsequently need to make sure that the hematuria resolves. So that's just a sort of secondary learning point, really, is that if you have a patient present with UTI symptoms, which is subsequently confirmed on an MSU, the then important thing is to make sure it resolves. And we'll come back to how we check that in the third case. The other sort of take-home message here is we're not going to treat unless he has some symptoms. Now, I'll pause only briefly with you, Shiv, because we're going to move on to our next case. But any sort of salient take-home points from that one?
I think you should carry on because a lot of the questions are things that I know you're going to cover. So I'm going to end up doing your talk. So I'm going to pause. I'm going to let you carry on.
All right. I'll carry on then, and let's talk about our next patient. So our next patient is Claire. Now, Claire is 51 years old. She has some gynae history. She is known to have fibroids. She's had heavy periods for most of her adult life. And actually, in the last few years, they've just been getting heavier. So as she was sort of late 40s, running into her 50s, her periods got, just progressively worse. And about 12 months ago now, she decided she'd had enough. That, all the management of menorrhagia that she tried just wasn't really cutting it. So she had a Mirena fitted 12 months ago. And that's actually made quite a lot of difference to her menorrhagic symptoms. Now, running alongside this, perhaps unsurprisingly, she feels that she's had sort of a full house of perimenopausal symptoms for the last 18 months. So, when you ask her, what sort of symptoms are you having, she can reel off pretty much every symptom known to man. And she has been suffering with this. So alongside the presentation that we're going to talk about is, of course, consideration of what else we can do to help with her perimenopause. Keeping focused on our talk for this evening, when you talk to her about her periods now, she says they're now becoming more irregular. They've certainly got lighter since she had her Mirena coil fitted. And she says it's quite difficult now to keep track of what is an actual period and what is just a bit of erratic bleeding. Because she says sometimes she'll spot for a day or two and then it all stops. And then, a few weeks later, she'll have a bleed, which goes on for a bit longer. And then she'll go a couple of months and then something else will happen. And her last significant bleed was 3 months ago. But Claire is typical for women who are, during their perimenopause, having a complete shift in their menstrual cycle. And it gets quite difficult for women to sort of almost chart where they are in their cycle. Now, along with all her other symptoms, she reports seeing blood in her urine 3 times in the last 6 months. And when this has happened, she says it's sometimes associated with some dysuria and urinary tract infection symptoms. And when that happens, it might have been around the time that she was spotting, but she's not sure. And each time she's had these urinary symptoms, she's been treated for a UTI, and she's had MSUs sent off on all 3 occasions that she's had this blood, and actually only one of them has confirmed an actual urinary tract infection. So it's quite a woolly story, isn't it? And there's quite a lot going on here, which is typical for our patients that come in with sort of slightly vague and protein history surrounding their periods, their urinary symptoms, and everything else connected to the menopause. So this is a multiple choice question. I just wonder how many of these symptoms you think are associated with the perimenopause. So which of these urogenital symptoms can occur during or after the menopause? And you can pick as many of these as you like. So we've got dysuria, we've got frequency, we've got hematuria, nocturia, stress incontinence, urgency, UTI, or the all-encompassing all of the above. Which of those do you think are related? Let's just give you a second to tick the boxes. I shall have a glass of water. The eagle-eyed amongst you will realise that my study is actually in the attic. So I can tell you that the thermometer up here tells me it's 30 degrees currently in this room. I've had to close the door because the kids are downstairs making a noise. The windows aren't open. I mean, the struggle is real, people. The struggle is real. Right. Let's have a look and see what you make of those smorgasbord of symptoms. Absolutely right. Look, there's almost half reckon it's all of the above, but we've got takers for pretty much all of them. And it's really interesting to note that the one which was least favourite for everybody was that of hematuria. So that's really helpful, and I will come back to comment on that in just a second. But before I do, I'd like you to answer just one more poll question about Claire. So here's our 51-year-old lady who has had 3 episodes of visible hematuria in the last 6 months. And on each occasion, she's been treated for a UTI. On one occasion, the MSU has confirmed an infection. Does she need further investigation at this stage? And if so, what would you suggest? So at this point in time, would you dip her urine to make sure that there's no evidence of bleeding now? Would you refer her to urology as an urgent 2-week referral? Would you refer her to urology on a routine basis, or would you just reassure her that this is likely to be menopause related and monitor for future symptoms? Just give you a chance to answer that. Okay, let's have a little look. So, majority of people, 70% near enough, are going to send Claire off for an urgent referral to urology. And then a few going to do it on a routine basis, and a few happy to just check to see that the bleeding has resolved. Thank you very much for sharing your thoughts on Claire, because this is the reason that there was a variety of answers to those questions is because actually this typifies the challenge that we have when it comes to vague presentation and, the presence of other comorbidities that could explain the symptoms that patients present with. And, this could all be related to perimenopause and her erratic periods, but it equally could be bladder cancer. And it's interesting that of all of those urogenital symptoms, actually hematuria is not commonly seen in the perimenopause. Everything else is, but not hematuria. So we can't, or we ought not to put hematuria down as being a perimenopausal consequence. That hematuria does need further investigation. And if you look at the guidelines again, we're looking at Claire's history. And actually, she is an urgent referral to urology, given that she has had visible hematuria that persists, or in her case, recurs after successful treatment for that UTI. So you could arguably say, well, she's had recurrent UTIs, so she's a routine referral. But actually, this was visible hematuria, and visible hematuria needs urgently looking at. And of course, alongside that, you would be thinking about sort of treating her urogenital symptoms with the likes of topical estrogen. She probably warrants a conversation about HRT once her visible hematuria has been investigated and that the underlying, or the potential for underlying bladder cancer has been excluded. Okay, let's pause now for Shiv to just have a little bit of any thoughts or feedback on those 2 cases, Shiv?
Yes, indeed. Thank you. I'm going to apologise slightly, Kate, because I'm concentrating on the questions, not really listening to you. So I hope that I don't repeat what you've already said, because I'm embarrassed to say because I've been looking at all the questions, I haven't always heard what you're saying. So there's a recurring theme of people I'm just going back to hematuria because it's always such a tricky topic. And there's a recurring theme of like retesting and rechecking. And one of the things, and sort of a new problem that has come up for a few people is frank hematuria. If that's been investigated, they've been told that it's fine, and then it comes back again. Do you need to investigate it again? I would say yes, you do, because you haven't found a cause for it. And okay, maybe the urologist didn't find bladder cancer, for instance, but we still need to think about the whole patient. Is there a renal cause? Could they have vasculitis? Could they have sickle cell? Is there something else? But I would say, yes, you need to keep poking around. It's not normal to have frank hematuria. So I would think you would want to keep looking for that. Several questions about managing the menopausal woman with who's on HRT. So someone's saying menopausal woman on HRT presenting with blood in the urine. Yes, Kate's going to actually talk about this, about the problem with bladder cancer being overlooked in women. So I'm going to let her actually talk about that in a moment. But yes, we definitely need to be looking carefully at perimenopausal and menopausal women, and not just to not brush it off, because that sounds rude. I don't mean that. But don't avoid that diagnostic overshadowing is what I'm trying to say. Don't let, she's probably got some vulval atrophy, so it's probably due to that. It may well be, but it could also be a bladder cancer or some malignancy within her genital tract, cervical or endometrial. So we don't want to do that. But what we can do is actually treat their vaginal atrophy as well as we possibly can, and then repeat the urine to see if she still has that persistent hematuria. And if she does, then get her investigated. So this is an interesting one. Thank you for sharing this. 13 years as a GP, as a gypsy cardiology, saw several cases with cancer, probably diagnosed earlier because they were on an anticoagulant. And there's a few of you saying, is it the anticoagulant? Is it the apixaban? Is it the edoxaban? But yeah, that's a really good point of, even if they've got an anticoagulant that might be making their hematuria more obvious, we still need to investigate it. I don't have an answer for this question necessarily. Elderly lady who's refusing to wash or have any hygiene after sex, having recurrent UTIs. Do I still need to refer her? I mean, yes, you've got a good explanation for the UTIs, haven't you? So at least it's not an unexplained UTI, but still, it might be that she still does need and warrant investigations. Someone's saying this exact thing about, you had a patient who was discharged, hematuria reoccurred, they were referred back, and the second time they found the bladder cancer. That's a really salient lesson for all of us. I think it's really easy as a GP to feel a bit like, I can't send them back to secondary care. They've already seen them once. They're going to think I'm a real pain. Doesn't matter. Be a pain in their ass. It's much more important that we get our patients diagnosed. So yeah, don't worry about that. Okay, back to you, Kate, because I think you're going to answer quite a few of the questions that are on here.
Lovely. Thank you very much, Shiv. And yeah, absolutely. Refer them back. I agree. If you think, I don't know off the top of my head what the sort of sensitivity of a cystoscopy is, but they're not perfect. They're not going to be 100% accurate. And therefore, a patient who doesn't have their bladder cancer diagnosed on the first look might well have that cancer picked up on the subsequent look. So by all means, refer them back. Do not be afraid to act on that spidey sense, that sort of clinical judgment that you have when you're worried about a patient. Okay, so our final case this evening is Anna. Now, Anna is 60. And let's imagine tomorrow morning, I will be due to doctor tomorrow morning. So Anna will be the sort of person that I look at and I think, thank goodness, when I see her pop up on the triage list, I will think, hooray, I know what is going on here. Because Anna presents with an acute history, 48 hours of dysuria, frequency and urgency. But she's systemically quite well. She doesn't have any back pain. She hasn't got any loin pain. She hasn't had a temperature at all. So this is one of those wonderful moments that we do still get amongst all the chronic disease and the uncertainty when you think you know exactly what is going on. So, of course, with that presentation, when you speak to Anna on the phone, you feel that actually UTI is the most likely diagnosis. Now, before we get into the sort of signing off that acute prescription and giving her some safety netting advice, you have a quick look back over her history and you look into her microbiology tab, and you can actually see that in the last 12 months, she's had 4 confirmed UTIs. So actually, Anna might not be as straightforward as we initially thought. And this would be a good opportunity, I think, for this would be one of those patients that you probably would want to firstly send another MSU off before you treat her, but also have a look at her urine and dip her urine. And when you dip her urine, actually it looks a bit cloudy. And when you dip it, it's got 2 pluses of blood, 3 pluses of leukocytes on that dip. So she evidently today has an acute infection. And we send off that MSU so that we can get confirmation of that. But my question really, and this is the last poll question of the evening, but my question is, what follow-up plan would you make for Anna? So let's just to recap, she's 60 years old. She has a likely probable UTI with the typical symptoms you'd expect. She's got non-visible hematuria when you dip her urine. She's had 4 confirmed UTIs in the last 12 months. And now we're wondering what subsequent follow-up we should do for Anna. So should we routinely refer her to urology given her history of recurrent UTIs and no further action is needed beyond that referral? Should we refer her urgently given her non-visible hematuria? Or should we plan to dip her urine again after her UTI has been treated to see if that hematuria persists? Let's just give a second to answer that. Okay, great. Thank you, everyone, for involving yourself in the poll. Let's have a look. Oh, look, it's a 3-horse race, near enough. Perhaps just out ahead, we've got the votes for dipping her urine once her UTI has been treated to see if that non-visible hematuria persists. So we'll talk a little bit now about persistent hematuria. There's a few, almost a third, think actually at this stage an urgent referral is necessary. And then a further third thinking that actually a routine referral given the recurrent UTI history is a good plan. Okay, so Shiv's talked a little bit, or she's mentioned the diagnostic overshadowing and why it is such an issue for clinicians when they are when they're managing women with urinary symptoms. And this was a really interesting primary care study that was published in the BJGP in 2020. And really looking at this issue of why women are diagnosed later than men, conferring the worsening prognosis. So there were 15,000 patients involved in this study. They'd all been newly diagnosed with bladder cancer. And researchers looked back at the stage that the patients had been diagnosed, what presenting symptoms they had presented themselves with, and any pre-existing conditions that may have been a barrier to making the bladder cancer diagnosis. And their findings are really interesting because they concluded that women were more likely to be diagnosed with advanced stage bladder cancer compared to men. So when you look at their results for these 15,000 patients, just over a third of men and almost 2/3 of women, once they had their bladder cancer diagnosis, actually had alternative explanations for their symptoms at the time they first presented. And the most common alternative explanation was UTI with hematuria. So this is where this diagnostic overshadowing, and this is a good example of cognitive bias, creeps in to our responses when patients present with a seemingly obvious UTI. We're quite quick to make that decision that this is a UTI, perhaps less good at thinking about the bigger picture, considering alternative diagnoses. And what they found in the patients that had presented with these alternative diagnoses, they were linked to later diagnosis in both sexes. But the conclusion from this study was actually pre-existing conditions such as UTI, that any condition that provides a plausible alternative explanation to bladder cancer were associated with later stage diagnoses. So the learning point for me when I sort of think about this study and its findings is that we need to consider bladder cancer as a differential diagnosis when we assess patients who present with symptoms of UTI, because we've got to try and pick up women at an earlier stage when we know that they can get better access to treatment, but their outcomes will be significantly improved. Let's just think about Anna's presentation for a second, because actually she's got two considerations at play here. Firstly, there's the history of recurrent UTI, because she's had 4 in the last 12 months. Secondly, she currently has non-visible hematuria. So thinking about the recurrent UTI for a second, if that was the only thing in her presentation that you were worried about, that would, given that she is 60, the sort of choice, the course of action to manage Anna going forwards would be a routine referral to urology for further investigation, given the NICE NG12 guidelines. But Anna's got non-visible hematuria, so it's worth just thinking about how we manage non-visible hematuria for a second. And it is worth bearing in mind that non-visible hematuria has lots of underlying causes. Menstruating females will have non-visible hematuria, it's thought, for about 3 days before their period starts. It can go on for up to 5 days after their period finishes. And it can occur post-intercourse and can last for up to 3 days in that scenario as well. So when it comes to the management of non-visible hematuria, it's a bit of a challenge, because certainly within the female population, there are considerations such as point of menstrual cycle and a sort of preceding sexual activity to bear in mind. Should we be using dipstick non-visible when we're looking for non-visible hematuria? Should we be going by a dipstick, or should we be relying upon the identification of red blood cells from the lab test? Actually, it's a dipstick that we should be using, because the lab test, something happens at the time in transit of the urine sample from the time it's taken to getting to the lab, and actually the red blood cells can denature and disintegrate and then give a false negative result. So we're looking for a dipstick positive. Ignore trace findings. Anything 1+ and above is notable. And just a note about dipsticks and how they should be stored. They should always be stored with a lid on. Otherwise, the dipsticks can oxidize, and that can give you false positive results. Is it persistent? And we've talked about persistent, and Shiv has already alluded to the fact that we're looking for, so when it comes to the definition of persistent, we're looking for 2 out of 3 samples being positive over a 6 to 8 week period. And actually, if you have persistent non-visible hematuria in anybody over the age of 40, then the positive predictive value for malignancy sits at about 1.5%. So it is definitely worth thinking about. So, quick question for you: when you think about how you're going to follow these patients up, and a bit of quality improvement activity, if you don't already have this in your surgeries, is to implement a process to ensure that patients with dipstick positive hematuria are followed up and have their repeat sampling done over that 6 to 8 week period. Now, how do you do that? Within our practice, we have access to Accurix. So we have got scheduled text messages set up that get sent to the patient, prompting them to bring their urine sample in. And actually, it has become one of the roles for our care coordinator to follow up patients that don't do as they're asked when it comes to the text messages. When you look at the guidelines for persistent and unexplained non-visible hematuria, they differ slightly whether you're looking at NICE or the Scottish referral guidelines, because in Scotland, anybody aged 60 or above with persistent unexplained NVH ought to be urgently referred. The NICE guidelines differ slightly here, because they recommend anybody aged 60 or above with unexplained NVH and either symptomatic dysuria or a raised white cell count. And Shiv's absolutely right when we talk about what do we mean by raised white cell count. We're talking about findings on a full blood count. And the reason for looking at their white cells on an FBC is because unexplained persistent nucleocytosis is a paraneoplastic phenomenon. So it's associated with a number of different cancers, but bladder cancer is definitely one of those that can put your white cells up. And if it is elevated, it's associated with a poorer prognosis. So my final thoughts on bladder cancer before we pass back to Shiv, just for a roundup of any final thoughts and comments. Delayed diagnosis of bladder cancer is incredibly common. 25% are diagnosed at stage 4, and overall 50% die of the disease. So this is something that we just need to have in the backs of our minds as a differential diagnosis, especially when it comes to women who present with urinary symptoms, because they are more likely to be diagnosed at a later stage. And unfortunately, because that diagnosis is made later, their prognosis across all of the age groups is worse compared to men. Intermittent hematuria is the most common presenting symptom for bladder cancer, and you only need one episode of unexplained visible hematuria to warrant urgent investigation. So, sort of summarising the nice indications for an urgent referral, it's essentially anybody aged 60 or above with non-visible hematuria, 45 and above with visible hematuria. And even if you have a patient outside of these age ranges, if you have clinical concern, think about the investigations that you can organise. Think about getting that sort of urology opinion in via advice and guidance if they don't meet any criteria. And then, of course, think outside the box and consider what else could this be. Could it be prostate cancer? Could it be endometrial or cervical cancer? Just, think about those patients in a more holistic way. Just a couple of quality improvement ideas for you. We've talked already about non-visible hematuria, but what about those patients who have recurrent confirmed UTIs? Do you have a process within your surgeries, your practices, to pick up these patients that have recurrent UTIs? And the real challenge here is that they're often diagnosed in different settings. So they'll present to out of hours with their urinary symptoms and be treated for a UTI. From a diagnostic point of view, it is a challenge, but it's worth just considering how those sort of out-of-hours reports come into the surgery, whether specific read codes are used in order to be able to facilitate a search of these patients, really looking for those recurrent UTI type presentations, because they would warrant a routine referral to urology. We've talked about hematuria and repeating those dipsticks. 2 out of 3 positive samples over a 6 to 8 week period is what we're really looking for. And I guess associated with all of this sort of follow-up of patients, there is, of course, that safety netting advice that we should be giving patients, sharing our uncertainty and explaining the importance that they do bring those repeat samples back so we can make sure the blood has cleared. Action Bladder Cancer UK have got some fab resources on their website. You will find links to those in the resources tab. But there's lots of good information for patients on the different types of bladder cancer. Actually, if you're not particularly au fait with the different terminologies that are now used, it's well worth having a look at that. And really, the symptom guide that we're talking about here, it's important that for us to know about almost as much as it is for the patients, because they will be coming to see us if they have those concerns. Okay, Shiv, have you got anything in the last couple of minutes to feedback from all of the questions that you've been answering?
Loads of questions. Thank you so much, everyone. Just a recurring theme again about the urine dips, about different challenges that people have, about when people drop the urine samples straight off to the lab themselves and that kind of thing. But actually this one, I love this question. Does everyone with UTI symptoms need a dip? Will we miss non-visible hematuria? Yes. I feel quite strongly about this one because those guidelines that came out from Public Health, I think it's Public Health England, I can't remember, a while ago, saying don't ever dip a urine in anybody over 65. You're always going to find loads of stuff in it. If you never dip a urine in somebody over 65, you'll miss their bladder cancer. And that sort of guideline drove me a bit mad because all my nurses picked it up and went, we can stop dipping those urines, can't we? And I said, no, you absolutely can't. So that was done in the context of urine infections. But yes, absolutely, I completely agree. We do need to be dipping those urines. And as we've just seen, hematuria is really important. One of our other colleagues who's a GP with a special interest in urology has shared some really useful information, which I've shared out with all of you about recurrent hematuria. The one thing I would say is thank you very much. That's really helpful for that. But that's when this is about when you should reinvestigate hematuria if it recurs. If you have found a cause that first time, like prostatic regrowth after a TURP, etc., I completely agree with you. I was really talking about the ones where the patient they've had a cystoscopy, they've been told there's no bladder cancer, off you go. It's for us to then still keep poking about if we haven't actually found it. I'm very conscious that I think, yes, it's 9 o'clock. We are now out of time. Thank you all so much for your great questions. I'll hand back to you to wrap up.
Thank you very much, Shiv. You have done a sterling job on the Q&A, so thank you very much for all your hard work. It's been absolutely fantastic to have so many of you here. If cancer clinics are your bag, if you'd like to join me for some future cancer clinics, then just a flag, next month I'm doing one with Prostate Cancer UK, looking unsurprisingly at prostate cancer. And then in September, once we've all had lovely summer holidays, I'm back doing one with cancer research, and we're going to be looking at lung cancer in September. So please do sign up and join me, and hopefully Shiv as well, for those clinics. When the webinar finishes, there will be a quick link to a Survey Monkey, which we would be really thrilled if you could just spend 2 minutes filling out. Just helps to make these clinics as useful and worthwhile as possible going forwards. Beyond that, have a fantastic rest of the evening. Thank you so much for joining us, and look forward to seeing you again soon. Bye for now.